After a gap of nearly 9 months, I would say, we have restarted our regular academic program virtually. Nowadays, mostly physical academic programs are being conducted regularly in our seminar room, 3 days a week, which is very, very regular. But my idea of doing pediatric dermatology webinars, we will continue with the webinars. I suggested to our academic committee of Institute of Child Health for the very fact and justifying the fact that this is the only way I can get the best brains of pediatric dermatology across India. Very easy to do it without any hassle of travel, stay, and obviously without the hassle of finance, big finance associated, and everybody can be there. Very easy method. This is something which is a great discovery during COVID times, I must say. This information technology's help has really revolutionized our knowledge sharing practice to a great extent. Nationally as well as internationally, we can connect with experts in the field just by sitting in front of the computer. So this great opportunity, I just wanted to take the best use of that, and that's why we have decided that we shall continue with our endeavors, which basically started from COVID days, 2020, from the very beginning. So friends, at the very outset, I would like to first welcome you all. I would like to welcome all our faculties. Welcome on board. And I would like to first say a few words about our Institute of Child Health, which has a very rich heritage. Many of you may not be knowing that Institute of Child Health is the first teaching pediatric hospital of the country. Let me, reiterate it. It is the first teaching pediatric hospital. It was established way back in 1956 by a doyen of pediatrics, Professor K.C. Chaudhary. And in 1957, next very year, it was inaugurated by the then Prime Minister Pandit Jawaharlal Nehru as the first teaching child hospital of the country. And we have all, specialties, almost all specialties related to pediatrics, pediatric cardiology, pediatric endocrinology, pediatric nephrology, pediatric immunology, pediatric rheumatology. And we have got a very rich academic program, teaching schedule, and we have excellent research products, coming out of it. We have 2 ethical committees. And how stringent are the ethical committees, I think Shahana knows to an extent. And, in our department of pediatric dermatology, which was actually established by Professor A.K. Datta, the famous person for vitiligo, by whose name we do our Vitiligo National Vitiligo Day. He was actually interested in pediatric dermatology also, many of you may not be knowing. And he established the Department of Pediatric Dermatology in 1995. And I joined the Department of Pediatric Dermatology in 1998. And after that, gradually, we have now a very good pediatric dermatology department. Dr. Raghubir Banerjee, Dr. Rajiv Malakar, Dr. Abhijit Shaha. We have, very dynamic faculties. Coming to today's program, friends, today we have got a very rich faculty. All are currently the torch bearers of pediatric dermatology of current days. And of course, Dr. Rashmi Agarwal is the young Turk, going to become a name in pediatric dermatology in the days to come. I'm quite confident about it. It is my privilege to introduce first our speaker today, Dr. Umesh Kumar Katakam from Hyderabad, Telangana. He is a pediatric dermatologist. He is an associate professor and head of Department of Dermatovenerology of Gandhi Institute and Medical College at Hyderabad, Telangana. He is the program director of IADBL Pediatric Dermatology Training Center He has been the Honorary General Secretary of IIDBL Telangana branch and coordinator of Chairman of IIDBL SIG Pediatric Dermatology. And he organized the first National Conference of IIDBL SIG Pediatric Dermatology, PedDermaCon, in the year 2019. Dr. Bhumesh Kumar has got a very rich CV, which, at the moment, if I go to keep on reading that, I think the entire webinar will be finished. But in one word, I can say he is a dynamic dynamite of pediatric dermatology. Welcome, Dr. Bhumesh Kumar. It is our proud privilege to welcome you on ICH, virtual media. Welcome.
Thank you.
So today's topic is something which is very interesting, I'm sure, for our pediatrician as well as dermatologist colleagues. Both of have joined, I know, and will be joining in next few minutes in more number, is the viral infections of the skin in infants and children, which are very useful, not only for academic purpose, but also for practical purpose in day-to-day practice of any dermatologist and pediatricians, not only the pediatric dermatologist. We have a very rich, panel of faculty of panels. I shall introduce one after another. First, Dr. Maitri Panda. Dr. Maitri Panda is the professor. Welcome, Dr. Maitri. Dr. Maitri Panda is the professor, PG Department of Dermatovenerology at IMS and SAM Hospital, Bhubaneswar. She is the current convener of SIG Pediatric Dermatology of our IIDBL. Maitri is one of the joint secretaries of Society for Eczema Studies, as well as coordinator for East Zone of SES. Maitri is one who has really nurtured many younger students. She's a wonderful teacher, and many of our students have participated in conferences, given their papers, which have been accepted not only in the country as well as abroad. Welcome on board, Maitri.
Thank you, sir.
Next is Dr. Sahana Srinivas. Dr. Sahana is the senior consultant pediatric dermatologist at Indira Gandhi Institute of Child Health, Bengaluru. Sahana is the research coordinator of Society for Eczema Studies, and Sahana works closely in our ISPD, has been working for so many years, and currently one of the associate editors for Indian Journal of Pediatric Dermatology. Welcome on board, Sahana.
Thank you, sir.
Dr. Resham Bhasani is the consultant dermatologist in Mumbai, and she is also the honorary consultant at Wadia Children Hospital, Mumbai. Resham is the current editor of Indian Journal of Pediatric Dermatology, a hardcore worker for Indian Society of Pediatric Dermatology for so many years, a very dedicated pediatric dermatologist. Welcome on board, Resham.
Thank you, sir.
And finally, our young dynamic Dr. Reshmi Agarwal is the consultant dermatologist at Cutis Institute of Cutaneous Science, Bengaluru, a very famous institute. And she is very upcoming pediatric dermatologist with a lot of interest in research. And Rashmi is in the research follow-up committee of Society for Eczema Studies. Rashmi, welcome on board.
Thank you, sir. Thank you.
With this, I shall go to Dr. Bhumesh and request him to start his deliberation. After Dr. Bhumesh finishes, then we will have a panel discussion. I'll request all those who want to ask some questions to put their questions in the chat box. I shall be moderating it. I am sorry to share with you bad news that Dr. Abhijit Shah could not join today because he lost his father yesterday night. So hence I shall be moderating the show. Now over to you, Dr. Bhumesh.
Yeah. Can you see me? Can you see,
Yes.
sir?
Yes, Bhumesh.
Yeah,
We can see.
So good evening to everyone. So thank you, Dr. Sandeep Pandasa, for your kind words and the motivation of all the generations of in the field of pediatric dermatology. So always we are very happy to be associated with you because almost we are working more than 20 years. We consider as you are our mentor. So always under your footpath, we are doing our level best to sensitize more and more in the field of pediatric dermatology. So, and thank you very much for the opportunity to speak on viral infection of skin in infants and children. Directly, so always I'll start with my brain teaser. So we know the whole world is running towards health and beauty. But remember, for health and beauty, both the important organ is healthy skin. So even for survival, if you want to survive, if you want beauty, if you want health, healthy skin is important. So the healthy skin awareness has to be initiated from the pediatric age group from day one. Because if you neglect the skin health, micro trauma will be takes place almost more than 80% by the age of 18 years. So it is the responsibility of every healthcare provider, especially those who are interested in the pediatric dermatology as well, the pediatrician, to sensitize the importance of the health from the day one. So because the intact skin will not penetrate any microorganisms, the intact skin will not penetrate any allergens or infections. So that is like a kavachakundal. So let us sensitize the healthy skin from the pediatric age group. So that's why healthy skin is healthy child and subsequently healthy body and healthy nation. Coming to the dermatosis, broadly, we need to divide two important aspects, the infective dermatosis and inflammatory dermatosis. So this demarcation is very important because especially the quacks or RMPs, they are using the topical steroids even in infective dermatosis. Let us sensitize broadly which is infective dermatosis, which is inflammatory dermatosis. Today, my concern in the infective dermatosis confined to the viral infections. I won't touch up a bacterial, fungal, protozoal infection, and I'll share my experience in viral infections. These are the common viral infections of the skin. I won't go in detail for the PG's point of view. Viral, like the six classical, the skin eruptions as a sign of general disease, like first disease, second disease, third disease, fourth disease, fifth disease, sixth disease, may be useful for the postgraduates. And the viral infection of the skin and mucous membrane also may present with a maculopapular rash. Majority of cases, almost more than 90% of children initially they present with a maculopapular rash. If you see the natural disease, some may progress into vesicular rash, and some may progress into arterial wheal, some may be progress into the purpuric rashes. And tumors, especially the human papilloma virus and pox virus, they may present with the tumors. If you see the pathogenesis, acute infection followed by viral clearance, usually the immune mechanism presented with exanthemas. If the rash on the skin, what we say exanthem, if it is on the mucous membrane, we can say enanthem. The best example is the measles. Whereas acute infection followed by the latent infections with the triggering. Latent infection with the triggering agents. For acute, the primary infection, the triggering agent is not required. But whereas latent infection to manifest clinically, there should be a triggering factor. Especially for the HSV infection, varicella zoster virus infection, HPV infection. And chronic infection, what we say, the HIV is the HIV asymptomatic, the complex of the syndrome. This I won't go in detail. So that comes under the chronic infection. And the most important thing, management. In the management, the most important thing is the accurate diagnosis, because we need to differentiate broadly whether it is the inflammation of the skin, whether it is caused by microorganism or whether it is caused by non-microorganism or any inflammatory process like psoriasis, eczema, although etc. What we have to do, just you can use our beautiful tricolor flag for the detection like a Sherlock Holmes. The history always, the history is the king in the field of medicine. My request to the younger generation, please try to spend little bit time with the patient. Patient will give number of clues to come to a conclusion of your final diagnosis. And cutaneous examination always very, very important. Always, what you say, image speaks. So when you see the cutaneous examination, we have to look for whether it is a macropapular rash, vesicular rash, pustular, or arterial, whatever it is. So the all 6 classical morphological lesions we have to observe. And always the skin is not only, be it the dermatologist, the dermatology is a surface medicine, but our vision should be beyond the surface medicine, because skin may be a marker of systemic diseases. So it is a responsibility of the dermatologist to look for the systemic manifestation. In majority of cases, sometimes they manifest on the skin, and that will give a clue for the detection of the systemic diseases. And of course, the treatment, majority of viral infections, the supportive therapy, always supportive therapy based on the symptoms. You have to give sort of supportive therapy, and in special conditions, specific antiviral therapy that we are going to discuss. And the most important thing is assurance. If you see adult, if one adult is suffering, the pain and pressure confined to that adult. Whereas in children, one child who is suffering, the pain and pressure that will not carry to the child, that will carry to the mother, father, grandparents, and subsequently they will reach to us. So managing the child is nothing but managing whole family. So that's why always I'll implement the formula of M square, because the medicine and mother or medicine or a caretaker. If it is a pre-adolescents, they won't take any medications. Always they are depending on the mother or father or caretaker. So always you involve the mother or caretaker or minds of the father, parents. Whereas adolescents, always you involve them. So because the adolescents, neither they are children nor they adults, always they won't follow the instructions of anybody, whether it is a father, mother, teacher, doctor, unless until you involve the adolescent in the treatment point. So always you involve the minds of adolescent. So, and one more important, we are not supposed to give orders to the adolescents. If you order, 99.99%, they won't follow our orders. If you advise, this is good and this is bad, this is a treatment you have to take. If you won't take treatment, these are the complications. 99.9% they will follow the advice of whether it is the parents or the doctor. So in a nutshell, so then these are the viral diseases, what you are seeing. So we'll see one by one. So if you see the prodromal phase and dromal phase, any child who is presented with fever, with a maculopapular rash, with the 3 C's, cough, cold, and conjunctivitis, or erythema of the skin, cold, cough, with a maculopapular rash, always we have to consider measles. So why the measles, the diagnosis is very important. I'll tell in the subsequent slides. So once if diagnosis 3 C's with a fever with a maculopapular rash, so as I said, the treatment is supportive and symptomatic with assurance. And in institutions, the laboratory diagnosis by the detection of IgM antibody. And the important thing, the best way to treat this measles is the vaccination. So MMR vaccine, mumps, measles, rubella vaccine, it should be given subcutaneously and at the age of 9 months, and the second dose will be given at the age of 15 months. The point to remember here is the MMR vaccine is a live vaccine. The maintenance of cold chain is utmost important. So no vaccine should be kept on the door side of the fridge. Always it should be in the middle compartment to maintain that cold chain. And why we need to diagnose the measles is the measles virus is responsible for transient immunosuppression of the child. That gives rise to the subclinical infection may become clinical, especially the developing countries like India. Tuberculosis infection may become a disease. So that's why the identification of the diagnosis of measles and supportive and symptomatic therapy is very, very important to prevent flare-up of the subclinical infection into the disease. And this is another child. Just like maculopapular rash and fever, so just it's rubella or German measles, all clinical manifestations just like measles. But how to differentiate these from that to this? So we'll see in the subsequent slides. Of course, so this another is parvovirus. This is a slap-cheeked or erythema infectiosum or fifth disease. So the diagnosis is purely clinical, and the treatment is there is no specific treatment, only supportive and symptomatic. Coming back. So this is a slide. So the differentiation of the measles to German measles to the erythema infectiosum is important, because the 3C, the prodromal symptoms are very prominent in the measles, whereas German measles prodromal symptoms are very short and mild. So almost all symptoms just like measles, but the child is not toxic. Whereas in the erythema infectiosum, the abrupt onset of high fever followed by about 10 to 15% of children, they will thrown the febrile seizures. So if the temperature is more than 100, those children may prone for febrile seizures. If temperature is high, we need to give antipyretics, especially paracetamol 15 mg per kg per dose. Along with that, cold sponging, tepid sponging is very important. Medicines, any antipyretic to reduce the temperature, it will take 2 hours. Whereas a cold tepid sponging within 20 minutes, temperature will come down and we can prevent febrile seizure and subsequently hospitalization. And this is a child neonate. Actually, during in my early days, I was confused. So the grandparent is coming with this. So Dr. Saab, so this is a child, so see the pigmentation. So I was confused what to do. And I was asking the history, so to think of. And next, the mother is coming into my chamber with a limp. So then I got the clue. And asked, do you have any fever? Yes. Do you have any body pain, joint pains? Yes. So my diagnosis I have reached. So that is the way the history is very important. I used to say history is the king in the field of medicine. It's nothing but, so the chikungunya, the chick sign in the neonates, almost 80% you will see the suggestive of chikungunya. So this is a way you can skin pick up the systemic diseases. Supportive therapy and assurance, the pigmentation to resolve minimum it will take 3 to 6 months. So of course this is okay. And if you see any child with a fever with this white islands in a sea of red, that is nothing but a dengue fever. So because a dengue, it's a spectrum, dengue fever to dengue hemorrhagic fever and dengue shock syndrome. So if you give supportive and symptomatic therapy at dengue fever, you can prevent the spectrum of dengue hemorrhagic fever and dengue shock syndrome. We, the dermatologists, if you see any white islands in a sea of red with a febrile child, so give plenty of fluids and temperature control, high the balanced diet and assurance that prevent the leakage and subsequently prevent dengue hemorrhagic fever and shock syndrome. Or sometimes children with just generalized erythema, just if you palpate the child, you will see the white islands. That is another way in some children they may present in this way also. So this is my experience when I was in Nilofer Hospital. The 9-month child, so history of fever, maculopapular rash, and they could not given any supportive and symptomatic therapy and progress into the purpuric rash. So the child came to Nilofer Hospital. We admitted the child, and we have done all investigations. It's diagnosed as a purpura fulminis due to dengue hemorrhagic fever. For this baby, we have given blood transfusion supportive. Almost it took 3 to 4 weeks to recover the baby. So this is the dengue hemorrhagic fever and dengue shock syndrome is a preventable conditions. If you identify at a dengue fever stage and give supportive and symptomatic therapy with the assurance, we can prevent the complications. And vesicular rashes, the viral diseases associated with vesicular rashes. If you see vesicular rashes in neonates, always we have to initiate the treatment for a specific therapy. That we'll see in a subsequent slides, because the HSV will come into the picture. The 1 and 2, even varicella and zoster, the angina, and iron foot mouth disease. What you are seeing that every day, almost 10 to 15 cases in every day-to-day practice. So herpes infection. So if you see multiple grouped vesicles on erythematous base, or multiple discrete vesicles on erythematous base, you have to rule out herpes infection. Because herpes infection, herpes simplex infection in adults is a benign. Herpes infection in neonates, it is not a benign condition. Herpes infection in atopic individuals, it's not a benign condition. Atopic herpes infection in immunocompromised, it's not a benign condition. In these 3 conditions, we need to give specific antiviral therapy. So otherwise, child may landed into complication. If you see, so this is a baby. Actually, when I was in Gandhi Hospital, my resident has diagnosed as insect bite reaction, and they sent the patient home. So we could not see. And the next day, we have been called to the NICU in the Gandhi Hospital. So the baby was throwing seizures, and immediately we did Jank test, and serology was done. It came positive for a HSV infection, diagnosed as a neonatal herpes meningoencephalitis. So we initiated the acyclovir, the IV, 10 mg per kg 3 times in a day. In spite of that, we could not revive the baby. So the wrong diagnosis is a mortality. So the delayed diagnosis is maybe mortality or morbidity. So with that bad experience, again after 2 weeks, another baby came to our OPD. So with here the grouped vesicles, here the discrete vesicles. But with this bad experience, we did the Jank test. It became positive. Here, what the baby is active, and we have given acyclovir oral 20 mg per kg per dose 3 times in a day. So within 7 to 10 days, all lesions were subsided, and the baby was active, and the baby is normal. So that was the experience. So whenever in the neonate, if you see multiple grouped vesicles or discrete vesicles, always you have to rule out herpes infection. If you don't have any facility, there is no harm in giving the specific antiviral therapy. We can save the children, or even if they survive, there is almost more than 50%, there is a morbidity will be there. So in the children about 2 years or adults immunocompetent, the supportive therapy is sufficient. So this is because the neonatal HSV, they divided generally in the first week, they may presented with the same type, skin, eye, mouth, 45%. If you diagnose here, if you give the specific therapy, you can prevent the CNS and disseminated type, because these 2 are poor prognostic factors. So this is a treatment, what I said, the same thing. And in the same type, only the for generally 2 weeks is sufficient. Whereas CNS and disseminated 60 mg per kg per, that means 20 mg per kg per dose should be given for 21 days for CNS, and whereas same type is only 2 weeks is sufficient. That's the only duration is a matter important. Whereas varicella zoster virus, as you know, the primary infection in the is varicella chickenpox. The reactivation is called the herpes zoster. So how do you manage this varicella zoster virus infection? So mainly it depends on the severity of the disease and the immune status of the child and age of the child. These are the three important factors to initiate specific therapy or not. Based on that, we have to manage. So here, if you see, the initial antiviral therapy should be initiated within 72 hours to get good result. But even if you delay it, there is no harm in giving if it is a severe constitutional symptom. The immunocompetent children, infants and above 2 years, we need to give acyclovir 20 mg per kg per dose. Remember, here we need to give 4 times a day because the varicella zoster virus little bit required the frequent 4-time doses. Whereas between 2 and 11, if the child is immunocompetent, no protein, no NAIDS, no AIDS. No, NAIDS means nutritional acquired immunodeficiency. Just give supportive and symptomatic therapy if there are no severe or no constitutional symptoms. Immunocompromised individuals, though age is not a bar. So irrespective of age, we have to give the specific antiviral therapy. So this is another experience. This is actually my child. Actually, they were in India and they went to Netherlands. So on the Monday morning, they sent the one photo is a few umbilicated vesicles. Then I said, we are coming to India. So by the next day, they came here, the severe extensive umbilicated vesicle, the severe constitutional symptoms. The eczema herpeticum, so it can be called herpes infection or varicella infection. So this is a child is atopic. Immediately we admitted this child. We initiated IV acyclovir in the pediatric hospital, 10 mg, the three times in a day. Should be given in the drip. So this acyclovir, the intravenous infusion, it can be available 25 mg per ml or 50 mg per ml. That has to be titrated. It should be given in a 50 ml of normal saline. It should go over a period of 1 hour. So you could see after 13 days, all lesions were subsided, but this pigmentation, it took almost 3 to 6 months. So any atopic child, if you see whether it is herpes or varicella, it has to be treated with a specific antiviral therapy. And this is another child. Actually, this came to Gandhi Hospital. History of vesicles, the same family history in another child, and they went to RMP, and they thought of drug reactions and initiated the oral steroids. And the vesicles and it became extensive and purpuric lesions, and they came to Gandhi Hospital. And we did the serology, and the serology has come positive for varicella infection. And that means the wrong diagnosis or wrong treatment may be landed into complications. So disseminated varicella. So if any history of vesicles umbilicated with family history, we have to consider the varicella infection, and message is, and the going to the specialist doctor is very important, because if they go to the RMPs, they may not know which is caused by drug or which is caused by disease. So if it is caused by drug, the treatment would be different. If it is caused by disease, the treatment would be different. So the message, always let us sensitize. So for any skin problem, there is a skin specialist. For that, they have to consult for the early initiation of treatment and subsequent to prevent the complication. Of course, the herpes zoster in HIV patients. So even the herpes zoster, before once upon a time, herpes zoster in a child, that indicates it's immunocompromised. So even we have done a study in our institution, where even immunocompetent individuals also you could see herpes zoster. But to differentiate in HIV individuals, that could be a bilateral or hemorrhagic or multidermatoma. So this is a clue to pick up to screen for screening for HIV infection. And another child, so actually this child is HIV positive. At presentation, so no prodromal symptoms, and immediately we initiated acyclovir, and I could see after 1 week and after 2 weeks. So there is no need to panic, even the child is HIV positive. So if you see the CD4 count 216, and we initiated, we could save the eye of this child. So always don't be panic. You try to spend time with the patient, give assurance and give specific treatment along with the supportive and symptomatic, and we could save the children. Here we have saved the eyes of this child. So to summarize the varicella zoster virus infection in children, so mainly to reduce the severity and duration of the disease and subsequently complications, especially eye complications or post. Fortunately, what we have done the post-operative neuralgia is very, very rare in the pediatric age group. The treatment options based on the patient's age. As I said, the infants, you need to give specific therapy. About 12 years, always morbidity is high. Again, you need to give supportive the specific therapy. And the severity of the symptoms, severe constitutional symptoms, you need to give specific therapy. And immune status, immunocompromised, irrespective of age, severity, we have to give specific therapy. So this same is a prospective study of herpes zoster children. So this we have done a study. If anybody interested, you can go to IJ. And the best way to treat the varicella is the vaccination. The varicella vaccine, it should be given at the age of 12 months. After first birthday, the varicella vaccine should be given. Again, this is also live vaccine. It should be given subcutaneous. Whereas the MMR also should be given subcutaneous. Again, the second dose after 18 months, the second dose may be given, or at the age of 3 to 5 years, it can be given. But the important thing, any live vaccine, the maintenance of cold chain is very, very important. Otherwise, then nothing but water. So of course, a hand-foot mouth disease, what we are seeing every day. But one thing, of course, the infectivity will be very high in the hand-foot mouth disease, but only supportive and symptomatic therapy is sufficient. But only few strains, the Coxsackie, the 71 strains may be associated with a cardiac involvement. So when you see any hand-foot mouth disease, the 2 points we need to ask: if you have any difficulty in breathing, and auscultate the chest to rule out any myocarditis. If these two are not there, just give assurance and supportive and symptomatic therapy. That is sufficient over a period of 7 to 10 days. Only in the atopic individuals with extensive, again, you need to give the specific antiviral therapy. So this is, of course, and herpangina, severe painful ulcerations. In these conditions, we have to give the supportive and the symptomatic therapy, mostly supportive. And COVID-19, well, the COVID, what we are in the pandemic, so that's why we are in the virtual. And the COVID virus may be the virus itself. Majority of cases, maculopapular rash. We worked in the COVID, the tertiary care COVID hospital, and mostly what we have observed is some maculopapular rash and arterial rashes, and mainly due to the personal protective equipments will cause sometimes the masking, aggravation of acne in adolescents, or the pigmentation on the nose, or even the using of the blips like a contact dermatitis, the PP-induced complications, and the impact of immunosuppressants in COVID. So whereas a COVID positive to initiate immunosuppressants, especially the childhood psoriasis, shall we go for methotrexate, all those things. So these are the 3 concerns when you are dealing with the COVID. And of course, monkeypox, again, it's has come into the India's first monkeypox. The one point to think of monkeypox, the vesiculopustular lesions in a child with prodromal symptoms, with initially the macules, papules, and vesicles, and the pustules. Generally, in the varicella, in majority of cases, you may see the umbilicated vesicles. Here, the vesiculopustular lesions is a clue to think of monkeypox. That's a message I want to give. I won't go in all detail. Yes. And the tumors, mainly the HPV strain, human papilloma virus, is all our strains. Of course, 74% of new infections occur among young people between the age of 15 to 24. So majority of the adolescents. The best way to treat this the HPV is the vaccination. We have a quadrivalent vaccination or a bivalent vaccine. This quadrivalent one. So at the after 9th birthday, the first dose should be given. Between 9 to 14 years, 2 doses with a gap of 2 months, whereas after 14 years, 3 doses with a gap of 2, 4, and 6. Because it may prevent cervical cancer, vulvar cancer, vagina, and genital warts also it may be prevented. So this is a doses. If anyway, this is again this can be given intramuscularly on the deltoid, and the problem is the injection vaccination induce some side effects will be there. always give this vaccine on lying down position on the delta region. After vaccination, you observe those child at least 15 to 30 minutes in our chamber. If there is no problem, we can send. So of course, the efficacy you could see the cervical cancer 98%, vulvar almost 100%, and genital warts is 100%. There is a protection. And once if they develop, these are all treatment options. I won't go in all detail. But one thing is the immunotherapy, intralesional immunotherapy. So what we are doing one study in Gandhi Hospital. So again, as I said, this is not subcutaneous. It is the titration of the important. The distilled water, it should be taken, and vaccine is a powder, lyophilized powder form. Once if you introduce in that, don't shake the vial. Just you rotate it, and that should be given intralesionally, and see that at the 30-degree angle, and it should reach to the dermis, because unless this the virus particle reaches the dermis, the innate immune system or interleukins or cytokines will not be activated. That is the main purpose, is to activation of the innate and adaptive immune system and release the cytokine, pro-inflammatory cytokines to activate the immune system, and subsequently that kills that HPV virus. Again, this is a cold chain. As I said, cold chain is important. So as I said, this is a 30-degree angle, and it should reach to the dermis to activation of the immune system. The 35 degrees angle. And again, this another, if you see the perianal warts in a child, so the perianal warts may be autoinoculation, perianal warts may be a sexual abuse, or this perianal warts may be active sexual intercourse. So these are the three we have to consider. But when you initiate the intralesional immunotherapy, because that's a live vaccine, so if you see the perianal warts, the immune status has been ruled out. Immunocompromised, the HIV screening has to be done before initiation of intralesional therapy. So in this child, we have done the screening, HIV was non-reactive, and we have given the intralesional. No need to give all lesions. If you take up any bigger lesion and give, and if you see after 2 injections of MR, all lesions were subsided. So this is the best way you could see some improvement. And again, you could see in the periangular warts after 4 doses, you could see the improvement. So again, after 4 doses, and this is a one child, even after 4 doses of MMR, there is no improvement at all. So why we can't understand? We want to do biopsy, but that we could not see the patient again for the follow-up. We missed it. Again, in some child in the interdigital area, so the bleomycin is another option. It should be titrated with the lignocaine because it is painful. So the each cc contain 1.5 mg. The maximum total dose should be given less than 2 mg, and the interval between the 4 weeks. So before that, we have to pair it, and then we can give the this bleomycin intralesionally. So you could see after 5 injection, all it was subsided. So we have to pair the lesions so to get better efficacy. As I said, again, the molluscum contagiosum. If you see the molluscum contagiosum, again, molluscum contagiosum on the face in an adult need screening, whereas in a child it can be a auto-inoculation. But if you see my giant MC in a child on the face, again it is a screening. So this is the immunocompetent child, and again this child is HIV positive. So whether again this will give a clue to screening of the systemic diseases. So these are the different treatment options. I won't go in detail, but one thing again, what we have done, so we have given the intralesional MMR therapy. So in the one lesion, so to activate the immune system, and you could see after one injection, the small lesions were subsided, but still the lesions are there, and subsequently we have given the dose. And other different extirpation, all those things. So finally, so take home message is The cutaneous lesions are extremely common and the only manifestation of many viral infections. So produced by direct replication in the epidermis or a secondary manifestation of replication of elsewhere in the body. So a stepwise approach is mandatory for accurate diagnosis by proper history and morphological type of lesions. And always give supportive therapy and assurance, because parents, especially mother, they will be everything they will consider it's an emergency. We don't know, especially any infective conditions, viral infection in the neonate, always we need to address and treat appropriately to prevent complications, what we have seen. The specific antiviral therapy based on the age and severity. So prevention is the best way to treat viral infections wherever it is, vaccination is available, because vaccination is the best treatment. Even it's the birthright of every child to vaccinate accordingly. So it is the responsibility of the parents to vaccinate their children to decrease the complications related to vaccine-induced infection. So thank you very much for your kind attention. So let us work for healthy skin and healthy child and body and healthy nation. So thank you very much.
Thank you very much, Dr. Bhumesh, for your extremely illuminating and magisterial presentation on a very focused topic in pediatric dermatology, but very useful topic for day-to-day practice, because I am sure our pediatrician colleagues, as well as the dermatologist colleagues, will be very much interested, must have been very interested. And I can see, questions coming in the chat box about your presentation. Thank you very much for the wonderful presentation.
Thank you, sir.
And now I'm very happy to invite all the panelists on board, and let us start our panel discussion. I particularly liked about your presentation when you said that for adolescent, don't order them. Yes, this is very, very important. Adolescent age is an age. And now we are handling an adolescent girl in our home. So if I ask my daughter to, you read these things, she'll say, I won't read. You read, I will teach you. So then I learned that better way of, teaching her is that you teach me. And she is very happy. She will start asking questions from her book. And that is the way she learns also. And she feels very happy that she is my teacher. So that was a very important piece of information, and that speaks volumes that we pediatric dermatologists also have to understand the psychology of the child. This is so very important for all pediatric dermatoses. Unless and until you give a good counseling to the parents as well as to the child, the treatment is incomplete. That was the message you conveyed, and thank you very much for that. Now, coming to another important aspect you have said, that is the chikungunya. Chikungunya is something which we have discussed in our Institute of Child Health seminar room, and when we, I think Dr. Raghuveer Banerjee showed the first case, many years ago, presenting with the cheek sign pigmentation. I found that most of our pediatrician colleagues, they were not much aware about it. And they were very surprised that chikungunya, neonatal chikungunya present like that. And, I was rather surprised because the neonatal chikungunya, classical cheek sign or pigmentation over the nasal bridge and the, the sides of the upper lip was first described by pediatricians only. Professor P.M.C. Nair from Kerala, who is a very renowned pediatrician, he reported it way back in 2008. Professor Rao from South India reported it in 2000, same year, and both in Indian Journal of Pediatrics only, not in our journal. And the interesting history of chikungunya, I think this is something which I gathered for all of our colleagues, that this is very important. That first chikungunya outbreak occurred in India is Calcutta. And the year I will never forget, 1963, because that is the year of my birth actually. And the second outbreak occurred in Maharashtra, 1976. And the third outbreak occurred in South India in 2006. After that, there was a long gap. The chikungunya, we thought that it has disappeared, just like dengue and many other things, and rickettsial disease, and they have come back. So nowadays, this is very important message. Once again, you have conveyed that whenever you see a newborn with this type of pigmentation, you should always take the history from the mother about the just antenatal history of joint pain, high fever, arthritis, like that. With this, I shall come to Sahana. Sahana,
Yes, sir.
I am sure that you have seen, few newborns with this type of chikungunya and chick science, and because you are doing a lot of fellowship programs in your institute, you are the principal investigators of the pediatric dermatology wonderful fellowship programs you have been doing. So, any studies you have done related to this?
So actually, we are doing the study for cutaneous manifestations of chikungunya. So in children, it's been over many years that we have collected the cases, and
Right.
we have presented that in few of the conferences also.
Okay.
So extremely in infants has, the pigmentation, centrofacial pigmentation is a very common presentation, the neonatal pigmentation. But we have also seen like vesicobulous lesions. They're also very common in infancy and very younger children.
Okay.
And SJS and TN-like presentation, multiple purpuric macules. So very superficial, tiny purpuric macules are also very atypical presentations of chikungunya, especially infantile age group. And the older age group, we do see this chick sign, the generalized pigmentation, acral pigmentation, flagellate pigmentation, which is quite very commonly seen in chikungunya. Apart from this, mantle-papular rash is not that very common as compared to adult. And joint pains also not very common as compared to adults. So these are the typical presentations what we see in children. Recently, we are seeing co-infections, COVID with chikungunya also we have seen, where they're present with centrofacial pigmentation along with purpuric lesions, especially the extremities, acrocyanosis also we have seen.
Wonderful. Because these things are very important, and that's why I wanted you to share these important informations with our colleagues.
So one more thing I just forgot, like we had a very rare case which with chikungunya with the dystrophic calcinosis cutis.
Yes.
So extremely congenital chikungunya presenting with multiple ulcers and then with the calcinosis cutis.
I was going to ask you this thing only next. Good that you anticipated it. Yes, thank you, Sahana, for your wonderful input. Maitri, can you talk now for a few minutes? I think
Yes,
you are
sir.
having, you are not well, having
No, sir.
cough and cold. In your institute, what is your experience of, seeing different types of viral infections in terms of frequencies in infants and children? Have you given any thesis topic to any of your students like this, or otherwise any study you have carried out?
Yes, sir. Sir, basically the pediatric department, they are undergoing many studies, sir, and we are seeing a lot of viral cases in form of herpes. So, sir, I think the predominance of herpes infection is much more, rather if compared to chikungunya or others. And in our OPD cases, we see a lot of verruca. But sir, these days, like Bhumesh sir has spoken, hand, foot, mouth disease is like a household term. But herpes infection, sir, and even many cases in pediatric ICU. I have been going to the ICU regularly for the dermatological consultation. And sir, we are seeing a lot of herpes patients, all different manifestations. The disseminated herpes, the varicella, which is almost like a very severe type of varicella infections. And also, sir, COVID, while there was during the third and second and first wave of COVID, I was actively involved in COVID hospital duty, and I was actively seeing the patients in pediatric cases. And sir, we observed a lot of cases, and also the MISC patients, sir.
Correct. So I shall come to cutaneous manifestations of COVID, in which you had earlier given a wonderful talk. I would like to know from Resham that Resham, you work in the western part of the country. We have heard from people from southern part as well as eastern part. Mostly now it is western part. of the country, Maharashtra, specifically Mumbai. So where people come from, not only Maharashtra, Gujarat, enter Western India. So what are the different types of viral infections you have seen in pediatric age group? In terms of frequencies, severity, and as Maitreyi said, as Bhumesh mentioned in his deliberation, that whenever you see a disseminated form of herpes zoster or anything which is very extensive, molluscum contagiosum or worse, you have to always exclude underlying immunosuppression, specifically HIV infections. So I think Maharashtra is a place where a lot of work has been done on HIV infections. And you yourself have also done some studies on HIV and other things. What is your experience on that?
Yes, sir. So, when we see the OPD patients, the most common viral infections we've come across is molluscum contagiosum and warts. And I think varicella is not something that we commonly see because most of the times the patients end up with the pediatrician. And herpes zoster, yes, occasionally we do see. Hand, foot, mouth disease is something very, very common. Every second, third patient has the condition in this current season. As we have the immunology OPD going on in the same premises on the same day, we do see a lot of disseminated mollusci, disseminated warts in primary immunodeficiency conditions.
Okay.
And I very strikingly remember a patient where the patient had very disseminated lesions. Lesions were not only on the face but also on the scalp, on the genitalia, and the child had Dockade deficiency as well. Further, we saw recently a patient with disseminated warts who unfortunately had received treatment from almost 8 dermatologists. The child had disseminated warts, huge warts on the dorsa of the fingers. There were periungual warts, subungual warts as well. He had warts on the scalp. Every possible treatment under the sun, including acitretin, imiquimod, intralesional MMR, bleomycin, everything was given. But nobody had investigated the patient for any immunodeficiency. So this child came out to be seropositive. The intriguing fact is that he was 11 years old, but his parents were negative. So, but his uncle was HIV positive, and that history was not extracted because it was not suspected. So that was something we could learn with that case. Further, chikungunya, yes, we do see congenital chikungunya as well, presenting symptom being just the chick sign. That is what we see in the NICU. Rare cases we do encounter in the NICU of neonatal varicella, and one just a recent case that we saw was herpes simplex virus with the infection with the SEM presentation.
Right. Thank you very much. Resham, that was a very insightful, thought, insightful sharing of the knowledge and your experience. That whenever you see disseminated lesions, you must exclude immunodeficiency, and please don't forget about the primary immunodeficiency, about which usually dermatologists are not that much aware, but definitely we are becoming more aware over last 1 decade or so, that primary immunodeficiency is no longer a domain of the hemato-oncologist or the immunologist. We, the dermatologists, should be able to think about it, because many of the primary immunodeficiency syndromes, initial manifestations come from the skin. So unless and until, isn't it? Unless and until we are aware, we won't be able to pick them up actually. What the mind does not know, the eyes cannot see. Right.
So one more,
yes.
just one more input about primary immunodeficiency, which we saw the case having generalized mollusci all over the body. Of course, there was no, it was not practical to offer any kind of a treatment for the mollusci. And this patient, after 5 years, we saw him, he had undergone a bone marrow transplant, and spontaneously all the mollusci had disappeared within a month of the bone marrow transplant. With scarring. Scarring is not something that we usually see, but then all the lesions were scarred.
Now coming to, Dr. Rashmi, Dr. Rashmi, you have passed out from Guwahati Medical College. That means you have the experience of the East, and you have been working in the largest center. I don't have any hesitation in calling it the largest center of a private, skin institute in the country. There is a Cutis Academy of Science. Do you find any change in the pattern of viral infections in infants and children? What you have seen in your postgraduate career vis-a-vis what you have been seeing over the last few years in Bangalore? Bangalore is the place where a lot of people, come. This hospital caters to a lot of people to not only Karnataka as well as surrounding states. So, what is your experience?
Yes, sir. Yes, sir. So, sir, during my PG days, there were a lot of cases of, I used to see a lot of viral exanthems mainly. So, a lot of cases of varicella, a lot of cases of herpes I used to see, which these days I'm seeing a little less frequently here in my private sector. There we used to see a lot of congenital infections. We used to see a lot of neonatal herpes also. So that I see less commonly nowadays. Again, varicella also, it is less commonly seen, but I see a lot of herpes zoster these days in children. So, lot of patients, like I get lot of feedback from my friends also. They'll send me photographs. Is this herpes zoster or is this blister brittle dermatitis? What is it? But they have those specific umbilicated lesions, the specific dermatomal distribution, the specific erythema will be there. So, a lot of herpes zoster cases I'm seeing nowadays. Regarding the other tumoral diseases,
In which age group you are saying, Rashmi?
I'm seeing in between 7 to 12 years of age, sir.
Okay.
Lot of cases, 7 to
Right.
12 years of age. I don't see it in the very younger age group, very lesser, but 7 to 12 years nowadays, lot of cases, sir.
Okay.
And in here nowadays, I'm seeing a lot of molluscum cases, too many cases of molluscum
Okay.
contagiosum. Hand foot mouth disease, yes, I'll not speak about it as everybody has already told. I think all of us are seeing a lot of HFMD cases these days, or the so-called tomato
Many.
flu.
Yes.
Yes, sir. Yes. So,
By virtue of the media, propaganda and all these things nowadays, parents come with the diagnosis. They say, my child has got hand, foot, and mouth disease. Doctor, you confirm, isn't it?
yes, sir. Yes, sir. And also, sir, hand, foot, mouth disease, like these days, what I'm seeing is there's a lot of deformation of skin. When the child is coming, they're coming with lot of deformation and lot of lesions on the buttocks, lot of lesions on the extremities, and very fewer lesions on the palms and soles. Recently, we had a child with cutaneous mastocytosis, urticaria pigmentosa. So the parents had sent us pictures that the child has developed a lot of bullous lesions. The child is not well, he's crying. So we thought it might be bullous mastocytosis. When they sent us the photographs, I thought it is varicella. But second day, again, they sent me photographs of one lesion on the palm. So I told them, you better come down here. So when we saw the child, it was a very extensive case of hand, foot, and mouth disease. It was not varicella. So we should
Yes.
not go by the pictures that they send.
Excellent. Very nice, experience you shared, Rashmi. I shall go to
And sir,
Dr.
one more thing.
Yes.
So in adolescence, I'm seeing a lot of periungual warts these days.
Oh.
Like apart from other areas, like lot of children with periungual warts.
And do you feel that this is because of their doing this habit? Children are in the habit of doing this thumb sucking and chewing the lateral nail fold and nail biting.
Yes, sir,
They might be contributing
Lot
to it actually, or by auto inoculation. Okay.
Yes, sir.
I shall be coming to Bhumesh now. There is a question from one of our colleague, pediatrician colleague, that the case which you mentioned, Dr. Bhumesh, that neonatal, herpes, which presented with herpes simplex, which presented with meningoencephalitis. And initially somebody could think of insect bite. How do you differentiate? That is what our pediatrician colleagues want to know.
So because here the neonate, the history is a mystery. You cannot get history in the neonates because parents, so sometimes parents they're busy, and caretaker always sees that the caretaker is also busy. So it's very difficult to differentiate whether it's insect bite reaction or it is a herpes. So for the benefit of doubt, if you see multiple grouped vesicles on erythematous base, the simple bedside test is a junk. If you go for junk test, if you see multinucleated giant cells, there's no need to go for serology. So we can initiate the antiviral therapy because there is no harm. Always, whenever you see the group, whether it's a group or discrete in the neonate, first it is our responsibility to rule out the herpes infection, because if you miss the diagnosis, the same may convert in second week into CNS type and disseminated, then the mortality, even if they survive, there's morbidity.
Right. Here, I would like to say that, I would like to have your opinion, all of your opinion, that I have seen many young, I am not talking about the neonates, many young children, they had this insect bite over the, ophthalmic division dermatome of the trigeminal nerve. And they had insect bite reaction, which was very bizarre in different directions. There was no uniform blisters, no underlying erythema, as Dr. Umesh mentioned. And I have seen many of them have been treated by our colleagues, either physicians or pediatricians or ophthalmologists, with acyclovir, thinking that at least I have seen 7 to 8 cases over last 10 years, I must say. And, this is very, very important. This is a message I want to give from this platform, very loud and clear, that it is very important to differentiate the insect bite reactions from herpes to prevent the, wrong treatment. Let me tell it very clearly, and give the proper counseling to the parents. Because the moment you diagnose them as herpes, particularly in the ophthalmic division, you have to take an ophthalmology consultation to rule out involvement of the cornea by the nasociliary nerve, which is known as Hutchinson's sign. So when you diagnose it as an insect bite reaction, either with topical steroid or with antihistaminic and topical steroid, you treat and it disappears soon. But here, whenever you are diagnosing herpes, then this course of the disease is altogether different, and you have to tell the parents accordingly, right? That it may be contagious.
And the site also important, sir. If it is covered parts, so first we have to consider the herpes. If it is an exposed parts, other than the clothes and the face
Right.
and outside, that as you said, apart from that, all the morphological lesions, we have to consider insect bite.
Correct. So anybody has seen similar kind of situations? Anybody would like to share your experience about that? If you don't want to, then I will go to the next question.
So but that baby now, we had that bad experience. So with that now, so not only me, my all colleagues. So whenever you see the vesicles in unit, first rule out herpes. So because
Right.
in front of us, that baby was gone.
Right. I think here, there is something which you suspect and you do over-treat. There is no harm in that. This is just like a Kawasaki's disease, So even in our Institute of Child Health, in several seminars we have discussed, and many experts have said that whenever you are thinking of Kawasaki's disease in a child, it is always better to go for an echocardiography if the patient can afford, because you are going to prevent something which leads to mortality in the child. So such echo is very, very important, even if suppose it doesn't turn out to be. So similarly, when you are suspecting neonatal herpes, it is better to be thinking in terms of herpes rather than insect bite reaction, which has got a much more severe consequences to follow if you are not able to diagnose at the very beginning, isn't it? So with this, I
and
will go
2 points related to hand foot mouth disease, 2 observations. So
Yes.
generally all parents, they will come to us first, so doctor, is it varicella or not? So if you say it is not varicella, they will be happy. So the distribution of lesions, observation, the history, that is very important. And recent past, the incidence of this hand foot mouth disease is increasing. So the reasons behind could be pulse polio, because the polio also enterovirus, Coxsackie also enterovirus. So at any point of time, the only one enterovirus will be there in the gut. So because of, we should say, thanks to the government of India, the pulse polio almost the trivalent to bivalent. Now we are bivalent polio. Now we inactivated polio vaccine they are giving. So by that, almost the polio virus has been eradicated from the gut. So whenever this one virus, enterovirus, which eradicated, another virus will come into the picture. So that's why this what we are the hand, foot, mouth disease also enterovirus. We are seeing number of cases.
Thank you very much, Bhumesh. I remember of this when you talk about this, pulse polio. I remember of our director, Professor Dr. Apurva Ghosh, who is right now in London with his daughter and and families, children. Just a very small vacation. Very tireless. So we call him Nelson's, working Nelson's. He is such a man of knowledge. So once we used to do clinic together 16 years ago, and one patient comes and telling doctor, where can I get the pulse polio done? A patient party is uttering pulse polio as a false polio. So coming from a remote village. So, this is important. I think this is how by contagious source you get these things disseminated. And another thing I would like to know from all of you, this is just to dispel the concept amongst many of our pediatrician colleagues, particularly, and physicians, that acyclovir does work in hand, foot, and mouth disease. What is your experience? I can see both all of you are nodding your head. It doesn't work, isn't it?
Yes, sir, it will not work.
Yes.
Resham? Sahana?
You are
No,
muted,
sir.
Resham. You are muted.
Yes. Moitrey? No.
So it has no role, sir.
Acyclovir, I think that message should go very clear and loud to everybody, that please don't give acyclovir. It does not work in hand, foot, and mouth disease. And what Bhumesh said, I fully agree that by and large hand, foot, and mouth disease is a mild disease, and a treatment on a OPD basis is enough. And you just give symptomatic treatment for fever, for itching, and tell the parents that if the child develops any systemic features or toxicities, suppose pain abdomen or diarrhea or anything, you have to admit the child, because enterovirus 71 is something which can be, a manifestation, which can manifest as hand, foot, and mouth disease, and which can have much severe consequences. Now coming to another very important question.
Infectivity will be very, very high. Any children who are there in the family, so isolation is important. So
Yes.
the rampant, today also I have seen almost 78 cases. So every day, almost 78 cases we are seeing.
Right. So, yes, it is very common these days, extremely common. And, many times it looks like something else, and unless and until you look all the sanctuary sites, which Rashmi said, that buttocks and all these things, then exfoliations. Another very important observation which we have, made, I would like to have your opinion. What is your opinion about that? Many times, this hand, foot, and mouth disease, after they subside after 1 month or 6 weeks, they develop, Bewes lines. Sahana, what is your take on that?
Yes, sir. This is something like a post complication of hand, foot, and mouth disease, and this usually seen 4 to 6 weeks after hand, foot, and mouth disease.
Yes.
So the most common complication is onychomatosis and Bewes line. So sometimes the hand, foot, and mouth disease are very subtle, so like 1 or 2, because we are seeing a lot of atypical cases. So they will not be knowing also that it is a hand, foot, and mouth disease, and when the child has it and it already would have resolved. So suddenly they come with this onychomatosis and Bewes line, and they think there could be a primary pathology there, but actually it's a post complication of hand, foot, and mouth disease. And it is a
Absolutely.
self-resolving. By 3 months, we have to just counsel them, and it resolves by 3 months.
But you can win the confidence of the parents, and the parents can think that you are a magician parents have brought a child with onychomatosis, and you say that your child had hand, foot, and mouth disease now recently, and the
Yes.
parents are impressed like anything. They look at you as if they are looking at the God.
Yeah.
Right? So
Yes.
this is the beauty of knowledge. Just by using that in a proper perspective, you can win the confidence of the parents, and that goes a long way. If you win the confidence, then the parents will listen to whatever you say. For any, not only for that child, any subsequent child they brings to you, for any other reason.
It's basically because of the nail matrix arrest during that period.
Correct. Correct.
And even if you ask the back history, and those who will have onychomatosis, those children who has developed severe prodromal symptoms, and the lesions also would be extensive, just if you take back history. And mild form, generally, you may not see the nail involvement. In the moderate to severe with the constitutional symptoms, those are the children's mean the future post complications, either Bu's lines or onychomatosis.
Excellent. I think this is a very good input given by Dr. Bhumesh. This should be one of the learning objectives, important learning objectives for our colleagues and our juniors, that when you see such onychomatosis, you should take a retrospective history that the disease was very severe, and that's why they have developed. In milder cases, they do not develop. And it is quite understandable. The nail matrix involvement needs a very severe viral load, a large viral load, as well as the severity of the disease. So now I'll come to you, Bhumesh. You have published, you have always been interested in herpes zoster in children. I have heard you speaking on that in, Hyderabad, 18 and 20 years ago. You were doing that work that time. And, could you share that somebody has asked that if you ask the parents with a disseminated herpes zoster or extensive molluscum contagiosum to go for HIV testing. This question I'll ask to each one of you, that how do you handle or counsel such patients? The parents become actually very much apprehensive. And how do you really, talk it out with the parents? How do you really dispel it? How do you really express it that your child needs an HIV test? So, what is your way of handling such children? How do you advise it?
Me, sir?
Yes, Bhumesh.
Yeah.
I'm asking. Yeah.
I'm very happy to answer, because as a TOT for NACO, so we have seen so many cases. Generally, if you see extensive herpes zoster, extensive means multidermatomal or with severe prodromal symptoms. In those conditions, you can initiate antiviral therapy. So 20 mg per kg per day, 4 times in a day. Generally, over a period of 7 to 10 days, all lesions will be subsided. So any persistent, even in spite of antiviral therapy, the persistent of lesions, that indicates because the immunosuppression, that the virus keeps on multiplying. So that is a clue to think of something is happened to the immune system. Those are the children's needs for the screening.
No, the question, you are right in explaining the pathogenesis, but our colleague wants to know that how do you tell it to the parents, and what is the parents' reaction usually, and how do you handle these parents? Because the moment you will tell that, look, your child needs to be, investigated for HIV infection. This is the HIV serology has to be done. Parents will become very anxious, aggressive, and resentful.
Yeah.
This is the very common reaction.
So the first, the treatment, when you start, I am giving the specific treatment. Generally, your child will improve over a period of 7 to 10 days. If the child is not improving, we need to do some specific investigations. As in the first step only, we have to tell. So then that is a way of counseling. And at the same time, we need to ask any in the family, for example, parent, mother or father, are they suffering with any immunocompromised condition?
Right. Moitri?
This is actually very difficult to counsel, but sir, probably telling something directly to the parents will not help. So maybe, sir, we just need to investigate because in our setup, it's usually a referral center, so it becomes easier for me to send the investigations rather than telling much of what usually the parents agrees, sir. But sir, actually, I don't know how to counsel. And sir, regarding the another question which you were asking about acyclovir, sir, because this Coxsackie virus is a RNA virus, and acyclovir usually has a DNA polymerase activity. So, sir,
Absolutely.
definitely it will never act. So that was
Yes, yes.
yes.
I wanted to hear it from you. Yes, correct. Sahana, how do you counsel such? You handle small children, I know. Genodermatosis. So,
I mean, this is also quite difficult to counsel. But when I see, suppose, an herpes zoster, which is involving multiple dermatome. So when I have to counsel a parent, I tell them that this herpes zoster is not that very common in children. So we see most commonly in adults. But if it is only a little few lesions are there, then I would have not. But there is multiple dermatomal involvement, and the child is a little bit sick. It's not that we are telling your child has this possibility, but has a routine investigation, and to know what specifically, whether it's associated or not, to give a better management, we would like to do this investigation. It could probably be negative most of the times, but as a part of routine and to understand this, we need to do this investigation. Like I do counsel like this, and they do agree for this.
correct. Resham?
Yes, I agree with Dr. Sana. The thing is that we need to be honest. I think if we explain the condition, if we explain the nature of the disease, and we explain then that this is not something that I would expect at this age, and it is likely that there is something wrong with the immune system. That's why the body is not able to control the infection and allowing it to spread like this, in layman terms, in their language. Then I would definitely tell them that I will be doing this test. Not that I'm suspecting it 100%. It may be positive, and hence, to be on the safe side for your own child's safety, it's better that we get it done.
Okay, thank you. Me?
Yes, sir. So I agree with whatever my seniors have told. One thing I want to say is maintaining privacy. So many a times I have seen when I talk about it, even if the fellows are sitting because I work in the private sector, so they will not be comfortable. So at times
Yes.
when these kind of patients come, I do take them to another room, or ask my fellows to just leave them alone for some, leave us alone for some time, because they are
Right.
not comfortable talking to everybody. They're not
Right.
comfortable talking when 2, 3 doctors are there. So that is important. Second important thing is when you're talking to an adolescent or a child, some 10 years old, 12 years old. So you should always see to it that you're not telling about these things suddenly in front of the parents. Because they become very skeptical. They'll start asking questions to their children. They'll start doubting them. So that one thing is very important, that we should first talk to the children and the parents separately. We should explain the parents that they should not be going home and then dropping so many questions to the children, because that will again cause a lot of trauma.
Right. I think, all of you have, given very important input. Rashmi, you have given very important input that they should be not told about this in public. In public means not in presence of other patients, and they should be taken to a different room. And in an adolescent child, it should be first, you should tell that child, adolescent boy of age 17, 18, and parents separately. These are very, very important for our examination, as well as privacy, as well as legalities also. This is very important from medical legal purpose. I shall be coming to medical legal issues related to dermatology subsequently. But what I want to add to this, the way I do, I would like to share with you that I tell the parents that, look, whenever any of our patient, either child or adult, comes with high fever or fever of moderate degree, we do a battery of tests. So these are routine battery of tests: malaria, typhoid, hepatitis, and all these things we do. Nowadays, COVID we do. So I tell them, these are the routine tests. Any child presenting with fever, these are being done. That does not mean your child has got malaria. That does not mean your child has got typhoid. But we have to do a screening test to pick it up at the earliest. It is better to know rather than do something unknowingly. So with this type of skin manifestations, this is our experience, and this is what we have read from the book, and this is what our teachers have taught us. This is what we have also learned, that with this type of presentations of the skin, extensive molluscum contagiosum, there is a small fraction of children who may be infected with HIV, and that is causing immunosuppression. HIV doesn't mean it is sexually transmitted. It may be just a needle prick. So how your child has got, that is a matter of guess. We do not know. But we have to exclude this. This is the part of the routine investigation, just like an investigation of anything goes on. So there are certain components of the investigation so that we can pick it up at the earliest. And this is for the benefit of your child. So all these things, when they're told in a very synchronized, comprehensive, and empathetic manner. Somebody has asked, oh, what about the emotional part of it? It all depends on the empathy you are showing to your patients. The other day, I was in Guwahati to talk to pediatricians in Northeast. Rasmi is smiling, Rasmi knows. So I said that your body language will, direct the parents that with how much empathy you are seeing a child. Honestly speaking, when I see a child with a very, very severe xeroderma pigmentosum having multiple malignancies, my eyes become full of tears. And that I have noticed, the parents notice that. And they know this doctor is trying to treat my child with empathy. So this is very important. Your body language will decide that how much empathetic you are to the child. So that will solve the problem to a great extent and acceptability to the parents, I believe. And this has not ever been a problem to any one of us, isn't it? So in our long practice. Now, there is another question which Dr. Umesh showed, perianal warts. Perianal warts cannot be taken lightly, and a strong suspicion of child abuse has to be thought about. Here I shall come to Resham. I know this is Resham's has done work, and she has talked about it so many times about POXO and other things and what is to be done, how these children are to be handled, what the parents are to be told. Could you just tell us, Resham, in a chronological manner, such children, how they are to be managed?
So first thing is to completely examine the child. So apart from the perianal area, we also need to see the other areas to look out for any warts, because strong possibility is also auto-inoculation, which is very common in this age group.
Right.
At the same time, we should also examine the caretaker and the parents and other people who are handling the frequently. We have to look at their hands, their body, if they have any warts elsewhere. And further, not only, if there are perianal warts, we also need to, sometimes it's very difficult to, look at the vaginal area. So it's important that we spend some time, we make the child very comfortable, and then examine the child in certain positions. Like, for example, if the mother can take the child in her lap and then retract the thighs, we'll be able to see the genital area better. So sometimes we may miss out certain warts because of the position of the child. And further, if we are suspecting genital warts which are possibly because of child sex abuse, we may keep that in our mind. We may not disclose it to the parent at the first visit itself. At the first visit, maybe what I did was that I advised other investigations, routine investigations like a complete blood count, urine routine microscopy, as well as to rule out other STDs like HIV, VDRL, HBsAg. And if and after that, when the patient comes back, spend some time with the history of the patient, like what is the patient like at home, who is taking care of the patient, is the patient alone at some point in time, also who is generally looking after the patient, is the behavior of the child changed in the last few days or months? Is the child not talking, or is the child behaving differently in school? Excessive crying, or not talking at all. These are certain behavioral changes that one should look out for. Also, certain symptoms like bedwetting, which was not happening all this while, suddenly has started happening. Or sometimes even encopresis, that is something also that can happen. Thumb sucking, these things which the child had left long back, now they tend to come back. Or sometimes the child is clinging to the toy and not allowing anyone else to touch, or not allowing anyone else to play with the child. That is something. So basically, behavioral disturbances are to be looked into.
That means the child is undergoing a mental trauma. You mean to say
Correct.
all these things suggest.
Yes.
Yes. Please continue, Resham. Yes, that is a very important thing. Yes.
Yes, sir. So, and further, if we are strongly suspecting child sex abuse, we need to be aware of the POSCO Act, according to which that even if we are suspecting child sex abuse, we have not proven it. But if we are suspecting, it is mandatory on our end that we report it to the concerned authorities. If we don't, we are liable to 6 months of imprisonment with fine. So this is something that we all should be aware of, that we are not going to investigate. We may not know who is the perpetrator. We may not even prove child sex abuse, but if we are suspecting it, it is mandatory for us to report. There are one-stop centers that are present in each district, and they have been established by the Ministry of Child and Family Health. And all the facilities like the legal, ethical, counseling, medical facilities, everything is available under one roof. And we can always contact these one-stop centers, and they will be further initiating the legal protocol, or we can inform the police ourselves.
Okay.
Also, one more point that we need to know is that we need not inform the parent. If it is possible, of course, we can inform the parent, but it is not mandatory on our part to inform the parent that we will be reporting the case. So these are things that I think, as dermatologists, whenever we suspect child sex abuse strongly, we should consider.
These are very, very important points, Resham, you have brought out. I knew earlier that you have spoken on so many forums about this, and you have got enough experience in this field. That's why I wanted you to talk about this, because many of our dermatologist colleagues also do not know about it. I'm sure many of our pediatrician colleagues also may not be knowing about it. So thank you very much.
And in continuation with Resham,
yes,
reporting to the police, it's very, very difficult for the healthcare provider. What we'll do in the institution, it's not a problem. If they come, you make that chit in a medical MLC. So once if you made it MLC OP chit, that is not a problem. That is the responsibility of police. Whereas if they come to our OP practice, in our private practice, the best way is we don't have such type of treatment. The best, it has to be treated in the institution. So let them go to the institution and make it MLC. So once if you made it a MLC, our job is over. Otherwise, even parents, they revolt on us. What you are thinking about my child, all those things. So that we have to face. Even we have faced that also. Working in the institution is not a problem. So we immediately, if you tell to that person, they will made it MLC OP chit. That's our job is over.
Right. Very, very, very correct point. Dr. Bhumesh. I think we have crossed the time, but anyway, we can go for another 3-4 minutes. After that, I would like to close the session. Bhumesh, I shall be coming to you. You showed very nice cases of giant warts treated with intralesional bleomycin injections. I would like to have opinion of others who are using it. It showed very exciting result. But I just want to know for my sake, as well as for my colleagues' sake, so do you need to do a pre-injection CBC LFT count, as well as in some children who has got a pulmonary function test compromised, need to do that, and follow-up you need to do that? Is there any absorption, systemic absorption from that injection to that extent that the blood level of it can be high, and it can lead to bone marrow suppression, LFT changes, or pulmonary changes in the pulmonary function test, because bleomycin is one of the things which causes pulmonary fibrosis. Yes, Manish.
Bleomycin, we have given only few cases, those who have not responded with conventional therapy, only few children. Only thing is the bleomycin after dilution, it's very painful. If you give normal skin, sometimes the children may went into vasovagal shock. So that's why, so equally we have to dilute with the lignocaine and see that injection, the liquid should reach to the lesion, and it should not be filled, it should not reach to the normal skin. That may cause necrosis and all the problem. Only limited experience, but the child was almost, it was cleared. And related to the warts with MMR, you also asked, no, sir?
No, I have
No,
not.
no. Okay.
Okay. Thank you, Bhumesh, for this very important input. I'm sure that all are enriched about it. Regarding the drug of choice for treatment of herpes zoster as well as herpes simplex, many times there is a confusion amongst the our non-dermatologist colleagues, even sometimes the dermatologist colleagues also. Whether acyclovir or valacyclovir or famciclovir. Interesting thing, I must tell you, the other day I saw a child with, having ophthalmic herpes zoster, and the ophthalmologist has given penciclovir orally. I don't know where from they could manage to get it. And, there has been no changes after penciclovir, because we know penciclovir doesn't work for herpes zoster. Topical penciclovir people have tried for herpes simplex, that is also not very effective, and there is no randomized control trial. So about the drug of choice for treating, this is a very simple question, but this is very important question, which I have faced so many times from our pediatrician colleagues. Each one of you just say 2 words about it, 2 sentences about it. I am starting from Bhumesh.
Acyclovir, sir. My choice is acyclovir. And if it is herpes infection, oral 20 mg per kg per dose 3 times. And see that the bottle, each 5 ml contains 400 mg. So that has to be titrated. If it is herpes zoster, the same 20 mg per kg 4 times in a day over a period of 7 to 10 days. My choice is acyclovir.
Sahana.
Yes, I do treat with acyclovir for herpes zoster. But for herpes simplex, not necessary you have to give acyclovir. You can just manage the child with symptomatic treatment only. Yes, sir.
Okay. Rashmi?
Sir, acyclovir is the choice. The safety profile and the effectiveness which has been seen with acyclovir has not been seen with the other antiviral agents, even evidence-based. So acyclovir is the choice.
Right. Resham?
Yes, sir, acyclovir.
Maitri, are you there?
Yes, sir. Yes, sir. I also prefer acyclovir.
Okay. I think the take-home message is very loud and clear here. That it is the acyclovir which is important, which is useful, which is time-tested, and there is enough data to support your treatment. As of now, the valacyclovir and famciclovir have not undergone enough clinical trial. We do not have data to support its use, in pediatric age. That is the message. I think we have come to the end of our, discussion. And I would like to take this opportunity to sincerely thank each one of you. Dr. Bhumesh Kumar, thank you very much. Very well done. Thank you very much, Dr. Maitri Panda. Wonderful input as a panelist. Thank you very much, Sahana, Dr. Sahana Srinivas. Thank you very much, Dr. Resham Masani, for your wonderful, input and accepting our invitation to join to all of you. And thanks a lot, Rashmi. You gave very practical input. Thank you very much for accepting the invitation, joining today, and enriching all of us. I sincerely thank all our colleagues who participated and interacted very nicely. I take this opportunity to sincerely thank our, vibrant, dynamic director. With his dynamic leadership, he has taken our institute to the next level. We have got great respect for him, Professor Dr. Apurva Ghosh. And, he gave us all freedom to preach and practice pediatric dermatology. We all are grateful on behalf of entire pediatric dermatology unit, on behalf of me, Dr. Raghubir Banerjee, Rajiv Malakar, and Dr. Vijit Saha. We sincerely, thank him. And all our, faculty colleagues in different specialties who have been always very supportive towards pediatric dermatology, very interactive, and we have learned a lot from them related to pediatric dermatology. I sincerely thank all of them. I sincerely thank the Dr. Reddy's lab, Glandera division, the regional business manager, Mr. Devobroto Sengupta. Dr. Reddy's lab, Glandera division has not only supported for this academic endeavor, they have been supporting us for more than 15 years in our Institute of Child Health for different academic endeavors. Thank you very much, Devobroto and your team. And last but not the least, I sincerely thank our cyber person, Mr. Somnath Mukherjee, for supporting always this virtual mode and helping us a lot and cooperating with us with all possible help. Thank you very much, Somnath. Thank you, everybody, and thanks, and see you again sometime.
Thank you, sir. Thank
Okay.
you very
Thank
much
you,
for the
sir.
opportunity. So
Yes, sir.
we have learned so many new points.
Thank
When
you
you
very
are
much.
there, we'll learn.
Thank you very much. Thank you very much, and wish you all a wonderful week ahead and weekend ahead.
Thank
Good
you.
night.
Thank
you,
Bye
sir.
bye.
Thank you, sir.
Good night.
Thank you.
Good night. Good night.